Good day, my name is Bob LeBeau, physical therapist with Body Gears. This is another episode of Masterclass. We're here with Kelly at the Oak Brook office. Today we're going to look at elbow, and the next series will go on for wrist and hand, but we're just going to work on elbow and finish off the upper quarter. So let's take a look at the posture here for a moment. So we're looking at the elbow, is she pronated considerably? Is she open? We'll have her supinate her hands. Does it supinate easily, or is it restricted? You look at Q angle, of course, to see if it's normal. If it's reduced, is it elevated? You look at girth, you look at symmetry. This is an area that has a lot of edema. Kelly doesn't have any, but if with injuries, there's a good amount of edema that could happen. And so we look at swelling or discoloration in the elbow to see what's happening there. Let's go ahead and have a seat. So elbow evaluation can be done in supine or sitting. I'm going to start with sitting just to make it a little easier. Either one will work fine. So when we're looking at elbows, we want to look at both flexion and extension, pronation and supination. Pronation and supination is more of a forearm thing, but that's the two motions. So pronation, supination is one motion, flexion, extension is the other degree of freedom, if you will. There's also varus and valgus that you'll have to consider. So we're looking at flexion, and just have her flex up to range of motion, and we always want to look at overpressure. So we're going to come over here and take a look at this. We're going to look at overpressure, give a little straight on overpressure, and then we're going to do a little bit more medially and a little bit more laterally. Because we appreciate the trochlea, the capitulum trochlea of the humerus and the ulna, you want to just see and challenge these two different positions. So we could challenge it in a supinated position. We could also challenge it in a pronated position. And that will give you some information on what might be tight. So she's very loose here. She might be more restricted there. We want to see if it's more of a medial elbow problem or a lateral elbow problem that we have to deal with. All right, so that's flexion. So it's flexion, kind of think of it with a quadrant. So we do straight flexion, we do medial flexion, we do lateral flexion, and we do pronated flexion and pronated flexion lateral, just to find out where the tightness is. You would then treat it, and once you find it. Extension, you need to, we're gonna turn it a little bit. And one thing you can do is take your hand like this and block the forearm and lock in like this. So the olecranon is between your fingers there. And you could just do a nice little extension, just locking that extension. You don't wanna do extension with the arm unsupported because it'll flop around. So you'll do this. You can also, if needed, you can put it against a wedge. Just make sure the shoulder doesn't come forward. So again, it's nice to block it. So we're going to do supinated, just like we did in elbow flexion. We're going to do supinated. We're going to do pronated. We're going to do pronated medial, pronated lateral, supinated lateral, supinated medial. Again, I need to lock in her arm a little bit as she's moving around a little. And that will give us a good amount of information to what part of the joint. Is it the ulna? Is it the radius? Is it the humerus? So you have those three joints that we have to look into. Pronation and supination, you can look at pronation, and it's nice to just get a nice grasp onto her hand and pronate, and then supinate the same thing, just turn around and supinate. I'd like to hold the elbow nice and solid to really just give a feel of the overpressure. Now let's talk about the joints again. Maybe we could switch arms so that the camera angle could be a little bit cleaner. Now I'm gonna raise up the table a little. So let's talk about the couple of joints here in the elbow. Just for sake of camera angle, we have the lateral most joint, which is the radius on humerus, and then you have the radius on ulna, and then you have the ulna on humerus. So if they have a lack of supination and pronation, it's really a go-to to look at the radius. If they have a lack of flexion extension, the humerus on ulna, so pronation, supination, you look at radius on ulna, flexion extension is the humerus. So let's go ahead and get a feel for this. So I like to take the joint and put it in an easy loose pack position. My finger grip is going to be fairly large, like a C grip. We're gonna go up and over. If you could come on and take a look at this. We're gonna go up and over and really get into the bone. So we have a lot of soft tissue mass here that we don't really want to pinch. So we'll go up and over and get onto the bone. Take a few moments and palpate. Very simple. You could palpate by pronating and supinating. Palpate and move around this to get onto this area. So you'll do a glide posteriorly, glide anteriorly, posterior to anterior. You could take her into pronation, which the bone stays in the same spot. It just twists over here, and you'll do the same thing, pronation, supination. So if she has a trouble with pronation, which is very common after an elbow fracture or elbow immobilization, you might have to bring her to her end of range and just mobilize the elbow to gain motion there. All right, so that's that one. Now, the radius on humerus, which is not as common of a restriction. The most common is radius on ulna and the ulna on humerus. But let's just talk about this one. We need to glide. This one would be more of a flexion or extension deficit. So if she has an extension deficit and it feels more lateral, that's why we look at medial or lateral. We'll try to mobilize it. Sometimes it's nice to put it on a little wedge, and you could sit there. So this blocks out the proximal aspect. And just be careful. There's a lot of soft tissue you're going to run into. We're going to lock in, and we're going to feel that, okay, it's trouble with either supination or pronation. Let's say it's supination, and we're going to feel this is, again, stabilized, and we could just get a little bit of mobility assessment and treatment. You don't need a lot of force, but if you want to, you could simply stand up and mobilize this way to get that radius on humerus. Radius on humerus can also be stuck in flexion. Very simple, you get into flexion extension and you mobilize either distally, like I'm doing here, which is most common, or proximal. Whatever seems to be most restricted, but that would be your flexion extension testing measure. Now the next one takes a little bit of force. The olecranon comes up like this on the trochlea, so you want to get into a perpendicular mobilization. Just think about where you're going to move. So if they're having trouble with flexion, I like to put it against my shoulder, so that takes that away. And I'll put my hand underneath here, and I'm just gonna lock in to get a nice little inferior glide. So it's important to really stabilize, as you see Kelly's moving back and forth a little bit, but really stabilize the joint. But you can get a nice little distraction, and that distraction really pulls that olecranon off the trochlea and allows that elbow capsule to stretch, so the capsule gets so stiff. So a nice little assessment of that. You can do this in flexion or extension. If you're going to do it into extension, you're going to need to help out with your arms a little bit. Just appreciate where is that, you be perpendicular, and where is that trochlea, because you don't want to be jamming into the coronoid process there. So you go in and do a little bit of anterior to posterior from this angle for extension. And again, appreciate that supination and pronation is generally a radial head problem, where flexion and extension is generally a ulna and humerus. So just a little assessment and treatment of that one. Another weird one, because we have both flexion and extension, pronation and supination as the two primary degrees of freedom, you also have radius and ulnar deviation. So you can take a look at, do they glide in an ulnar way, a varus, and a valgus, to see where they have some trouble. This is something I won't do right away. I'll do this a little bit later, but they can have some restriction of the capsule, and just doing a varus or a valgus assessment in different angles could really help to give you some information on where to treat. Just mobilize it with grade 3 or grade 4 oscillation to help that along. The elbow is oftentimes, after immobilization, oftentimes restricted from a soft tissue standpoint. The biceps doesn't get involved too much, but you're looking more distally. I should say biceps, long head, the muscle belly. But distally, if we would take a look at what's going on, there's a lot of muscles in here that intersect. If they have tennis elbow or something more painful laterally, you could find that these muscles just don't play as well. And you feel, get out your anatomy textbook so you know which muscle you're on, The extensor carpi radialis brevis is the one with the Maudsley sign, but you'll go in there and you'll feel restriction, and you can really dig out tightness. Some people might do a friction massage, or you could just get in there and work on perpendicular deformation of that muscle to allow that to free up. In the anterior aspect, this might be restricting both folding with flexion or elongation with extension. And if they're having restrictions, just feel for the pronator teres or the biceps or any of the flexors. Just take a moment and feel where the restriction is. Now, as Kelly is getting closer to extension, there's a little bit of tightness here. She has great full extension, maybe a few degrees of hyperextension. So I think I'm just kind of close to the end of her normal play. But always look at one side to the other and see what's normal. If they're restricted, there's going to be a handful of muscles that's tight. Posteriorly, I'm going to rotate you a little bit. Posteriorly, you have the anconeus that maybe have a trigger point. You may have some tightness in the tricep. Typically, these guys, the flexors and extensors, aren't where the problem is. It's more deep into the cubital fossa and the little muscles around the joint, or the restrictions at the insertions that you want to take some time to free up. All right, so the elbow is a fairly straightforward hinge joint, but you do have varus valgus, you do have supination, pronation. So just go ahead and when you're just doing a flexion and extension, move on and do a lateral and medial assessment to check to see which side, what part of the quadrant you're going to look at. And then that'll help you focus more treatment on one side or the other, and make it much more efficient. The elbow could take a lot of force. There's a lot of force that goes through it with pushing and pulling. So when you're getting in doing the manual work or even the exercise work, you could really put a lot of force on there to help it out. If they've had a recent fracture and the doctor says don't do any manual therapy on it until they're completely healed, active range of motion and soft tissue work is key to helping them out. So go ahead and do your evaluation, find the restrictions, and go ahead and treat them accordingly. Thank you.